So good morning guys again. In my last video we have already finished with the general surgery, and from today we will start with the systemic surgery, and the first topic will be the breast. So breast is a very high yield topic, and in every exam there is at least 3 to 4 questions asked directly from the breast. So this notes I have made it is very high yield and it is very easy for revision because it is finished in 4 pages, and I have included all the high yield points as well as the most repeated topics in it. So let's start with the new topic, which is breast. So what is breast? So breast is a modified sweat gland. So the most important thing in breast is the lymph node. So in the breast the lymph node are divided into level 1, 2, 3, and it is divided based on the pectoralis minor muscle. So lateral to the pectoralis minor is level 1, behind it is level 2, and medial to it is level 3. There is also one question is the tissue of breast which goes into axilla is called tail of Spence, and it is the most common tissue which is falsely identified as a lump. Okay, so when a patient comes to the OPD and you have to have to check the breast, so how will you do it? So if the patient is very young, you have to do either USG or you have to do MRI. And what is the reason for it? Because the young patient have very dense breast tissue and you will be not able to differentiate between a lump and the normal breast tissue. And if the patient is adult, you have to do a mammogram. All right, then another most important question they ask about the screening, and when will you start screening. So the annual screening for a normal female coming is 40 years of age, but if the female has a family history of breast cancer, the screening age will be 35 years. If the patient has a BRCA gene mutation or a first degree relative who has the BRCA gene mutation as well as history of breast cancer, then the annual screening should be 25, and what you should use is MRI because 25 years is still a young age, and that is the reason you will use MRI. Other than that, you can use mammogram for it. The most important score is the Biret score. The Biret score, in that you have to remember, Biret score 3 means once you have done the biopsy, it is probably benign, but you have to investigate further, and you have to ask the patient to follow up for every 6 months. Biret 6 is biopsy proven, and after that you have to perform surgery. Then the question asked in pathology is, what is the investigation of choice for the biopsy is true cut biopsy, and that is incisional biopsy. What is the gold standard? Gold standard is excisional biopsy. What is the investigation of choice for staging? Staging, which means the patient has cancer and it has been metastasized. So what will be the investigation of? It will be PET CT, and what we will use as a dye is 18-FDG. If the patient has BRCA1 gene mutation, it is in chromosome number 11q, and it is mostly found in female, and it increase the pathology as well as it has a very worse prognosis. Then BRCA2 is 13q, and it is usually found in male breast cancer. Then about the lymph node. So about the lymph node, okay, so the most important is about the sentinel lymph node. What is sentinel lymph node is? It is the first draining lymph node of a cancer, and how you will find out that the cancer has been metastasized into other places? You have to inject the dye in the dye is methyl blue, and you have to inject it in periareolar region, and the first lymph node which will show the color, that will be a sentinel lymph node. And also if it has been metastasized to other lymph nodes also, they will also have the blue color. So what is the minimum amount of lymph node removed during a surgery? It is 10. Okay, now what are the risk factor of a cancer? It is increase in age, early menarche, late menopause, and nulliparity. So you can understand that as long as the female the female who has high number of reproductive phase, the risk factor for the breast cancer is high. Is there any contribution of OCP? No, there is no contribution of OCP in the breast cancer. There is no protective effect. What is the most common metastasized place is the vertebral column, and it is used by Betson plexus, which is a venous plexus. This question was asked in January 2025. Now you have taken the biopsy of a lymph node. Now what will be in the immunohistochemical pathology? Then it is divided into receptor, which is estrogen, progesterone, and HER2/neu. So it has been divided into luminal A, luminal B, HER2/neu, and basal. So what does it mean? So in luminal A, ER/PR is positive, HER2/neu is negative, and it has the best prognosis. Luminal B is called triple positive, in which all is positive. HER2/neu is ER/PR negative, HER2/neu is positive. Basal is triple negative, which has the worst prognosis. Now we have found the histochemical properties. Now how will you treat it? So in any cancer you have to give chemo. So you have lymph node positive. So what chemo agent will you use? You will use etriamycin and cyclophosphamide. What is the toxicity of cyclophosphamide? Is hemorrhagic cystitis. This is one question. This was also asked in Jan 2025. If HER2/neu is positive, you will add one more drug, which is Transumab. If the patient has only ER positive, PR positive, and HER2/neu negative, which is luminal A, which has very best prognosis, what will you do? If your patient is premenopausal, you will give tamoxifen, which is a SERM. If the patient is postmenopausal, you will give anastrozole, for example, letrozole. Okay, this is done. Then TNM staging is very important, and most of the question has been asked from it, but the very important thing is you should remember about the T4, T4A, T4B, T4C, and T4D. T4A is there is inclusion of chest wall, but there is no inclusion of pectoralis muscle. T4B, if there is word like paw day orange or there is any kind of ulceration, it is directly T4B. T4C is chest wall inclusion is there and skin is also included, and there will be dimpling of the skin. It is directly T4C. What is T4D? T4D is inflammatory breast cancer, which is the worst breast cancer, and it has the worst prognosis. So these four you should definitely remember for the exam point of view. Now you have done everything. Now it's time for surgery. So what will you do? So the most important and repeatedly asked question is regarding modified radical mastectomy. What we do is we remove the breast, the nipple areolar complex, we remove pectoralis fascia, we remove lymph node 1, 2, and 3, plus we also remove pectoralis minor. What we do not remove is pectoralis major. And what is saved in modified radical mastectomy is A, B, C, lady, which is A for axillary nerve, B for bell nerve, which is given to serratus anterior, C is cephalic vein, and lady L is nerve to latissimus dorsi. Okay. Now, what is the most common injury during the surgery is the injury to long thoracic nerve, and how will it present is by winging of scapula. Now after that, what is the most common complication of a surgery is formation of seroma. Okay, seroma is the fluid which has been drained by Romovac drain, which we have studied seroma. And other than that, if it is not treated, then it can cause lymphedema, which means one hand has edema in it, and another hand is normal, which is called lymphedema. And if this lymphedema is also not cured, then it can cause lymphangiosarcoma. So this is the most common complication of a surgery. Now after surgery, if you want to reconstruct the breast, what is the most common flap used? So most common flap used is TRAM. TRAM is transverse rectus abdominis myocutaneous flap. This is one liner, and this is usually asked. Now here comes the very important part, and from this only in my January 2025 3 questions were asked, and I will tell you about it. And you should read it together, because in the option are so similar that you will fail to differentiate based on the history. So you should read all these diseases together, so you have very less chance of making any mistake. So the first is mastitis. Mastitis means it has some inflammation. So the most common cause of inflammation is Staph aureus. The history will be the mother is breastfeeding and there is crack on nipple. The mother has fever, she has pain. Okay, then this is mastitis. What is the treatment? We have to give antibiotic and we have to give analgesic. Suppose we have given antibiotic analgesic and still the patient does not cure and the treatment fails, then it can cause into breast abscess. If there is breast abscess, there is additional history, which will be there is fluctuant mass, patient has fever and patient has a lot of pain, the breast is very reddish in color. So what you have to do, you have to perform a USG, you have to find a breast abscess, and then you have to do a incision and drainage. Now the third is galactocele, which is also called as lactocele. This question was asked. Also the breast abscess was asked. See, these both are very similar, but there is a difference. In galactocele, the patient has history of breastfeeding, okay, but there is no pain, there is no fever, and the only problem is the milk duct has been blocked and it is painless, the baby is not able to feed. So what will you do? So you have to tell your patient to do a massage on the breast and then try to feed the baby. So see, these are very similar but still very different. So that is the reason you have to study all this together so you don't make any mistake. Now the fourth one is called duct ectasia. Duct ectasia, if there is any green discharge from the nipple, then it is directly duct ectasia and there is dilation of lactiferous duct. What is the treatment? If there is only a single duct pathology, you have to do microdocotomy, or if there are multiple duct pathology, you have to do head-filled surgery. So this is done. The next one is duct papilloma. If the history has bloody discharge from the nipple, then it is duct papilloma and it has papillary growth of lactiferous duct. The treatment is same as duct ectasia. Either you do microdotomy for single duct or you do head-filled surgery for multiple duct. Now the sixth is fat necrosis. This is also one of the option which people gets to confuse is what is fat necrosis is if the patient has a history of trauma on breast or on mammogram there is a lead pipe appearance, then it is a simple fat necrosis, okay, and this is benign condition. Then the next is fibroadenoma, which is also called as breast mouse. So the history will have there is a lump which is free and mobile, it is painless, and on mammogram there is popcorn calcification, then it is a fibroadenoma. The treatment is lumpectomy. The another one is cystosarcoma phyloid or phyloid tumor. Always remember, phyloid tumor is a very big tumor. See, phyloid tumor is a very big breast tumor, mass or tumor which is unilateral. Also there are dilated veins, and on mammogram there is leaf-like pattern. This is caused by due to hyperplasia of stroma and it is non-fungating. Remember, if there is any fungation of breast and there is a lot of bleeding, then you have to think about cancer. It cannot be a benign condition like phyloid tumor. Okay, now the next is mastalgia. Mastalgia is cyclical pain, usually on the beginning of cycle or the beginning of the period. There will be pain in the breast, which is a normal physiology, and the treatment for it is either you give vitamin E and primrose oil capsule. What is Paget's disease? Paget's disease is when there is nipple plus areolar complex has been destroyed and there is eczema like feature, it is called as Paget's disease. What is invasive ductal carcinoma? If there is a unilateral breast pathology, the breast is firm and it is very rock hard, there is dimpling of skin, then you can think of invasive ductal carcinoma. Why there is dimpling of skin? Because the mass or tumor is at the suspensory ligament of Cooper, which is pulling the breast skin. That is the reason there is dimpling of skin. And on pathology, it has stellate infiltration. This is invasive ductal carcinoma. Now comes the invasive lobular carcinoma. The history will be simple. On HPE, there is single file pattern and there is decreased E cadherin. Inflammatory breast cancer, which we have studied, it is direct in TNM staging is T4D. The keywords are, or the buzzwords are, peau d'orange. And what is the reason of peau d'orange is due to the blockage of subdermal lymphatics. What is Mondo's disease? Mondo's disease is a thrombophlebitis of lateral thoracic vein of the breast. And what is the treatment? Treatment will be analgesic. Now the last one is, what is gynecomastia? Gynecomastia is enlarged male breast tissue, and this is also benign, and usually the treatment is liposuction. Okay, so here we have finished the breast topic, and this is the very high yield points I have covered here, and most of the question are asked here. So from these 2 pages, 1 2. And another question was asked is on the inflammatory breast cancer, and the buzzword they given is pause orange. So see, it is very simple question they will ask. You should remember that FMG is a screening exam. It is not an entrance exam. So you should know the basics rather than mugging up the whole deep things like TNM staging, every line, what will you do, how will you do, what is Centimag, how will you perform chemotherapy, what is radionucleotide, what type of camera is used. This is very high level things. At your level you should remember the basic thing, how will you differentiate diagnosis, what will be the basic management, because you are a general physician, you are not a surgeon right now. That is the difference between the pattern of FMG, NEET PG. If you are going to solve the PYQ, you will definitely see the difference in the pattern of NEET PG and FMG. So use these notes. This is very easy and very high yield. That's it for this topic. And the notes of this topic will be in my Telegram group. The Telegram group is Dr. Prince. Okay, and also the link will be in the description box, and please subscribe to this channel. I am putting a lot of effort for you so that you pass your exam in the first attempt. So you should also put a little bit of efforts for yourself. This topic is like 15 minutes. I have recorded it in 15 minutes. Even in 2x speed you can finish this in 7 minutes. In 7 minutes you will have at least 4 to 5 questions from this topic. Okay, so just put a little bit of effort and do read your main notes as well. Thank you. And the next topic will be of thyroid. Okay, thank you.